Hannah, I understand you're back again with another pun for us.
Oh, thank you, Hannah.
Unfortunately, I'm so sorry, Paul. So our next entry in the highly competitive, high-level NephMadness / Curbsiders pun competition is from Dr. Mimi Berk, who submitted it to us via our Instagram page. If you guys are ready for this one.
I'm ready.
Hey, what's up, you guys? My name's Mimi Bach. I'm a third-year internal medicine resident at the University of Arizona in Tucson, and this is my joke. Why did the nephrologist stop diuresing the patient who drank too many pumpkin spice lattes?
I don't know.
Because she was getting a little too basic.
What? I don't even know what that is referring to.
That's like a millennial thing.
Okay.
Yeah.
I love that one. It's
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect the official policy or position of any entity aside from possibly Cash Like More Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
This episode of the Curbsiders is sponsored by the American College of Physicians. ACP is proud to serve as the professional society for internists and has over 154,000 members. For a limited time, doctors can save $100 on their first-year membership dues. Visit acponline.org/join and use the code CURB100 to get your discount. That's acponline.org/join and use the code CURB100 to get your discount.
Hello, everybody. Welcome back to the Curbsiders. And we're not going to do a full intro tonight. I just wanted to quickly remind you who our guests are for this episode. This is our second NephMadness episode. We talk about inpatient hypertension. Should you be using as needed medications for high blood pressure in the hospital? And we talk about hypertensive urgency versus emergency. We also talk about the use of perioperative ACE inhibitors, which is a sort of evolving topic in hospital medicine and perioperative medicine. And if you haven't heard part one, you should go back and listen to it. We have three wonderful guests also on this episode. There is the great Dr. Joel Toth, our chief of nephrology at Kashlak Memorial Hospital. You can follow him on Twitter at kidney_boy. He is, of course, the co-creator of NephJC and NephMadness, and he has been on many Curbsiders episodes in the past. He's also an award-winning educator. Our second guest is Dr. Pascale Khairallah. She is a second-year nephrology fellow at Columbia University, and she is an editorial intern at the American Journal of Kidney Diseases. She actually was the one who wrote the great post for the hospitalist region that you can see on the AJKD blog. And our final guest is Dr. Charlie Wray. He is an academic hospitalist and researcher, also works for the Journal of Hospital Medicine as both a director of the editorial fellowship and as a digital media editor. So without further ado, we'll get on to the show. First, we jump into picks of the week, and then we'll go on to talking about inpatient hypertension. Thank you, and enjoy the show. I always have to, because I like to hear him speak so much, I always have to give my co-hosts, especially the great Paul Williams, a chance to give a pick.
Yeah, happy to as always. It's not going to be medically related as always. And I'm feeling guilty. I think my last pick was actually suitable for children. So I'm gonna change things up back to my usual. I'm gonna recommend the Comedy Central TV series Corporate. I don't know if you guys had a chance to see this.
No.
It's a series. It's created by Pat Bishop and Ingrid Bretson and Jake Weissman, the latter two who are actually stars of the series. And it's basically about these two schlubs in middle management trying to get their way up to like upper middle management. And it's, if you've ever been part of a gargantuan Kafka-esque institution where the wheels kind of grind no matter what happens and what you do, I think you'll appreciate it. It is nihilism probably at its funniest. So if you ever had the displeasure of working for a large corporation, you'll completely relate. But I think even if you work for any kind of large system where you're just kind of screaming into the void, you'll probably also relate. And it's really, really funny, really dark, and obviously not for children. So I'm going to recommend Corporate, now in season 2.
Stuart?
You know, I just want to like air some dirty laundry because I was talking about the Expanse a couple of episodes ago, and I purchased season 3. Yeah, so
are you retracting again?
No, I'm not retracting. 5 days after I purchased season 3, it went Prime. So season 3 is now Prime, but literally it happened right after I purchased it. Wonderful show. It's really all I watched the last couple of days. I binged it.
So, and let me air more dirty laundry. I happen to know that Stuart tweeted at Amazon and asked for a refund because this is true. So check now before you get a chance, before you delete.
I got a refund though.
All right. Well, I think that's the best advice that we are going to get on the show all night. Is that if if it goes Prime right after you purchase it, Amazon will give you a refund.
Yeah. Jeff Bezos has bigger concerns right now. This episode of the Curbsiders is sponsored by the American College of Physicians. The American College of Physicians is the professional home for internists and is the largest medical specialty society in the world. There are chapters in every state, so you have tons of local opportunities to attend meetings, learn, network with colleagues, and add your voice to advocacy discussions near home. ACP is known for its high-quality evidence-based education programs, and membership includes a free subscription to the Annals of Internal Medicine and all of its extra multimedia features like In the Clinic and Beyond the Guidelines. Members also get discount on critical resources for lifelong learning like MixApp and the annual Internal Medicine meeting. ACP remains a fierce advocate for our profession and our patients, doing things like offering input to the ABIM on ways to improve the MOC process, lobbying Congress to reduce administrative burdens, and remaining vocal on important policy issues like gender pay equity and reducing firearm injuries. I'm proud to be a member of ACP because it has served as my professional home for many years. Please check out acponline.org/I am proud to hear more stories from our colleagues. No matter your career stage or practice setting, ACP can support your needs. For a limited time, post-training physicians can save $100 on their first-year membership dues. Visit acponline.org/join and use the code CURB100 to get your discount. Join the ACP today and be a proud part of the internal medicine community.
So our topic here is PRN hypertension. Stuart, I believe this case is for you.
That's right. Mrs. Brigham is an obese 66-year-old female with OA and hypertension who presents to the clinic and is found to have a blood pressure of 198/122. In fact, my technician was very anal and rechecked it 3 times in both arms. You know, what is the difference between... hold on a second. I got a little vomit in my mouth.
Oh, my gosh.
Hypertensive urgency.
That's definitely going in the show at the end.
No. It's because he had that word, hypertensive urgency. I threw up a little bit when I saw urgency. And hypertensive emergency. Oh, goodness. I can't even say that.
Okay.
So what's the difference?
All right. I think Charlie, I think we should start with Charlie on this one.
Yeah, I think this is one of these classic things that we're taught in medical school. What is the difference between urgency and emergency? And the simple answer is, I think, as a lot of us look at, is emergency. Both have elevated blood pressure. Classically, we think a systolic above 180 and a diastolic above 120. But the difference, of course, is in the idea that there's end organ damage that's associated with hypertensive emergency. And what is end organ damage? And it can be something as simple as mental status changes in one's vision, chest discomfort, and having a heart attack by all regards, pulmonary symptoms of shortness of breath. One of the more classic ones I think we sort of look for and think of, and I'll give a shout out to my nephrology fellows here, is of course, any sort of renal damage as well. And so we look for signs and evidence, I think, of end organ damage is I think the term that we associate with hypertensive emergency over urgency.
So I want to ask you a slightly metaphysical question that's not on the script here. Do you believe in hypertensive urgency?
Oh, God, I'm glad. There have been papers. I think I've read probably half a dozen perspective and opinion papers over the years about the idea of, does hypertensive urgency exist? Or is this just sort of one of these made up things, sort of like pre-diabetes, where we've put a label on something at this point in time, and then all of a sudden it sort of became a disease state. Right. I have fallen into the category of, I believe it's sort of a made up state at this point in time. And if there are no hard endpoints, if there's no physiologic damage caused, and if the patient doesn't actually realize, something bad is going on, is it really a pathology, I guess, in that sort of setting? So I've had this internal debate, and lots of other people have had this debate as well, and I'd love to hear what you guys think too.
I think it's like Tooth Fairy. Well, my problem is that if you call something, if you give us this horrible name and you send them to the ER, the doctor's like, well, Mr. Smith, you've got hypertensive urgency. And he thinks, oh my gosh, I'm dying. Now I have chest pain. Now I'm having blurry vision. Now I'm having a headache. And then next thing you know, they're being admitted for their hypertensive urgency that they've had for years and years and years. And so I think we've got to be careful because the nomenclature itself can be damaging.
Okay, Stuart, you're a coding guy. Is there an ICD-10 code for hypertensive urgency?
I believe there is, actually.
I thought there wasn't.
I'd have to look it up. I actually don't know off the top of my head because I never even looked for it. I-16.0, hypertensive crisis. So that actually includes hypertensive urgency. So it's 16.0, hypertensive emergency 16.1, and unspecified 16.9. So there you go. There's your answer.
So I've taken to writing acute hypertension or acute severe hypertension in the chart rather than, and if it's hypertensive emergency, Joel, maybe I'm misattributing this to you, but I heard someone say this, like, hypertensive emergency looks like an emergency. Like the patient's not just sitting there like chilling in bed. I don't know if I'm attributing that to correctly, but that's what I've been saying to people and to patients. I mean, if you have a patient that's sitting there with a systolic blood pressure of 190 and they feel fine, they're like surfing Twitter on their phone, who cares? You have plenty of time there to fix that blood pressure.
Yeah, no, I mean, they can look fine and still have heavy proteinuria and acute renal failure, and they don't look bad, and you'll see, biochemical evidence for end organ damage, even though they are not suffering.
But nobody seems to look for the proteinuria in the ED. That's one of my sticking points.
Joel, we have no shortage of labs at Kashlak, so I'm usually looking at a patient that's been fully labbed up, surfing their phone, and I'm pretty convinced there's nothing bad going on here. But that brings up a good point. Let's say someone systolic blood pressure 190. What basic workup do you recommend?
You got to find a medical student who still has his ophthalmoscope. So it's going to be a third year early in the season, right? Don't try to find a jaded third year, almost a fourth year. They'll never have the ophthalmoscope.
I still have my ophthalmoscope.
Paul, I guarantee
you are going to make
Williams,
a great third-year medical student one day.
Paul Williams was the only person in our residency program that was carrying an ophthalmoscope at all times. He was
darn tootin'.
He was the best. He probably still carries it.
It's no longer functional. It's been used to death, I'm afraid. So I've still been too cheap to get another one.
Pascale, what are you doing? What is your approach to this condition, hypertensive urgency? Do you think it exists, and how do you handle it?
So since I've been in med school, I've only heard about it, so I think it exists. I think basically it's just a high blood pressure that needs to be treated, and there is no emergency in treating it. I think looking at actually the guidelines, just to bring some guidelines into this, the American College of Cardiology says like patients with hypertensive urgency should not be admitted to the hospital, should not go to the ED, and should just be followed as an outpatient. And they
probably shouldn't tell them they have urgency. I'm so sorry, I didn't mean to speak over.
And then actually, like, if those patients are sent to the ED, the American College of Emergency Physicians says don't even give them any IV medications. Really, the treatment of these patients is in the outpatient clinic, where they're followed by a nephrologist or a primary care doctor who can increase their anti-hypertensives. I don't know that it exists. It's just high blood pressure without end organ damage that needs to be treated before you get end organ damage.
I think my philosophic concern, and I'm on the fence with this, about hypertensive urgency existing. I just don't want to see the pendulum swing back too much the other way where we're laissez-faire about it. Because I think there's the difference between a person standing on the edge of a cliff and the person at the bottom of the ravine is just a step, right? Like, and it's the same person. So even though it's not something that needs immediate, acute, aggressive intervention, like I don't want to see I've seen my learners actually sort of become almost kind of casual, like, yes, they're Systolic's 220, so I told him to eat less salt, and we'll check him next week. Like I don't know that that's quite the right approach either. So I don't want to forget to treat the actual hypertension because I still think it's not good. Like I think that's an important point to retain during this discussion. It just doesn't warrant admission.
So Paul's in the do not randomize the diastolic greater than 120 to randomized controlled trial.
I think that empiric trial has already happened. I think we know what happens. Right.
Charlie, your journal recently published a things we do for no reason on this, right?
Yeah.
What was the gist there?
Yeah. So as many of the listeners probably know, I think Tony Brew wrote this article on the PRN utilization of hydralazine or labetalol in patients with hypertensive urgency. And basically the take-home message was, stop. We don't need to be doing this at this point in time. And the reason is there's no real data to actually support the use of PRN anti-hypertensives in these patients. We all know that, hypertension as a chronic disease, of course, is bad, and we should control it. And we should aim to sort of control it on that level. But there's just no data to actually support that bringing it down acutely is actually good. And then the few studies that actually do exist actually show that there are adverse outcomes of when we try to sort of aggressively lower somebody's blood pressure from lightheadedness, dizziness, falls, syncopizing, and that sort of thing. And so just by I think we oftentimes get sort of relaxed in the idea of, just give him 10 of Hydral, his blood pressure will come down and he'll be okay. But for every time you do that, of course, there are again sort of the consequences to that. And I think that's what a lot of hospitals are coming around to sort of recognizing.
Yeah. You beat the drum to the next patient that we have.
Right.
And I think it's doctors being expected to have an answer when they get the phone call.
That's right.
Right.
Yeah.
Right. And, I think this is one of my favorite sayings, and people who know me well have heard me say this, is one of the things that I will oftentimes share with my learners is don't just do something, stand there. Right. And so oftentimes the system asks us to react to something. And, we are commonly taught to react. You have to do something. But this is one of those situations where you don't have to do something right now, but let's look at their blood pressure medications. Let's readjust, their home meds while they're here. And let's think about underlying causes for actually why they're actually hypertensive. When our hospitalized patients become febrile, tachycardic, or hypoxic, what do? We work up for the reasons for why they're doing that. But blood pressure seems to be this funny one where we don't look for other reasons commonly, but we just go ahead and treat it. So it's one of the vital signs that sort of we treat differently than the rest of the vital signs sometimes. And I find that odd.
I love that you said that it's that thing we treat without actually doing anything about it. So you're totally right. I think even there was this one study which shocked me where only 7.5% of patients in the hospital who got IV PRN medicines were actually seen by a physician. And maybe 1% of those actually had an emergency. So it's probably just a resident who got a call and wants to react to the high blood pressure, and the nurse wants to check the vitals again and see a better blood pressure without actually assessing the patient, knowing whether the high blood pressure is because of pain, because of anxiety, because someone forgot to resume their home medicines, because they've been pumped with 5 liters of fluid in the ICU and now they're super overloaded. So there's lots of reasons that we need to address first before giving the IV medicine.
One of the points that came up in one of these studies, I think it might have been in the Things We Do for No Reason article, is that primary care doctors are seeing lots and lots of these patients, and only a very small percentage are actually getting sent to the emergency department. And I think that's just and that the study that was highlighted was saying that there's not really a difference in outcomes in those patients, other than probably days spent in the hospital. Paul, do you remember that?
That's exactly right. Yeah, the only metric that changes, you were much more likely to get admitted if you were sent to the ER at 30 days. And I think even 6 months, your mortality, your blood pressure, all of it was exactly the same. So all you did was just expose them to hospital risks.
Yeah. And it's so disruptive to their life. The the whole hypertensive emergency thing, before there were blood pressure medications, those patients, when they were having blood pressures in the 200s and it wasn't treated, if they were dying within a year, many of them. So that's why we know it's a serious condition. It's just now, I think the better option is to, in hospitalized patients, look for things like pain, anxiety, missed medications, volume overload, etc., and then go up on something that's going to be more long-acting or part of their chronic regimen.
Do you ever run into the problem where you're trying to admit a patient, though, and you're like, I'm going to put them on the regular med-surg floor, and the med-surg floor is like, their blood pressure is 190 over 120. Yeah, we're not going to accept this patient until the blood pressure is less than 180 over 120.
Yes.
You ever run into that problem?
That is, yeah.
Yes.
I don't know
because then you're kind of like stuck between rock and hard place. You talk to, the charge nurse, the bed coordinator, like, yeah, his blood pressure has been this way for like 7 years. So we're not going to change it overnight here. Let's treat a COPD exacerbation.
Charlie, do you have any sort of workaround for that situation?
Yeah, I agree. I've oftentimes, whenever I've talked about this topic with others, you oftentimes sort of come to the conclusion that this is information that not only should physicians know, but our nursing colleagues should probably know this information as well, because they're the ones who are gathering this data and then sharing it with us. So this is one of these things that's going to probably take years and years to trickle down. But I do agree we need to sort of work together with our nursing colleagues on understanding the importance or lack thereof of this.
Right.
Yeah.
I think we've lost our chief here.
Yeah. So no, while we're screwing around, like I gave a psychiatry grant rounds on just outpatient management of high blood pressure, since they don't get that talk very much. And one of the poor guys whose job it is just to get people to inpatient psych facilities, is like they won't accept with these so what agent can I give PRN just to get them out the door? And I was like, that's not anything I'm going to actually answer. But they're in this position where they literally can't discharge the person unless they have this absolute number that they have to meet. And
yeah,
we talked about that with,
it's absurd, but it's just
with it was, I think, Scott Weingart. We talked. He's an emergency medicine physician. He was like, he goes off on a rant on this because he goes, yeah, we know the person's sitting there, their blood pressure's 200. We know they're going to be fine. We just started some oral medications, but I have to push IV Hydralazine to get them out of the ER because the floor won't accept them. And I think he was actually advocating that the primary doctor shouldn't have sent them there in the first place because they were asymptomatic. But you can't.
There's a lot of systems flaws there you could talk about.
Yeah.
Yeah. Next thing you know, you have RRTs being called overnight.
Right. And not every primary care office is set up even to do like urinalysis and check a creatinine, an EKG, a chest X-ray if you're worried enough to do those things.
And it's not always primary care officers that are sending them. So sometimes it's urgent care centers.
Yeah.
So that's a huge issue.
Or call centers,
Yeah, or call centers too. I checked my blood pressure and it's 220 over 120. Oh my gosh, go to the ER right now. The next question should have been, what's your normal blood pressure?
I have literally had patients come in. I work in our urgent care at the VA, and I've literally had patients walk in saying, I feel fine. I called into the nurse hotline. I told them my blood pressure. They told me to immediately come here. And I looked at them. I was like, great. Did you forget to take your blood pressure medications this morning? Yeah, I was traveling. Okay, take them and go home.
That's great.
Justin, do you want to break in? Did we miss anything?
No, the only things if we wanted to talk about are the specific risks associated with acute management, like the dropping of the blood pressure. And I think there was something in the write-up about how there's not really good follow-up, and this is just something that is not well taken care of as a primary care issue.
Joel, did you have anything else?
I guess there's two things I'd like to highlight. So one was the observational trial. They looked at crazy high blood pressures in internist office, and internists could either send them to the ER or send them home with follow-up, and then they looked for difference in outcomes. Now, this is, of course, is just observational, but there was no difference in outcome whether they sent them home or to the ER, and that really has reassured me in my management to just, hey, I know you have high blood pressure. Let's change your management. Let's change your medicines. Let's make sure you're actually taking your pills, and let's see you in a week, rather than, frog marching them down to the ER to get IV medications that who knows what's going to happen. And I just know in general, sending patients to the ER is going to result in a unhappy experience. Like nobody likes going to the emergency room. And I only try to do it if they really need it. I really try to avoid that at all costs. If I can get them, if they need to be admitted, I try to get them directly admitted. And if I can send them home and manage it as an outpatient, I try to manage them as an outpatient.
Pascale, did you find anything about the specific risks of treating with IV hydralazine when you were going through the write up here?
Yeah. So one thing I think to note about hydralazine. So hypertensive emergencies need IV medications for treatment, and depending on what kind of emergency or what kind of what organ is involved, you choose what IV medication to give. And actually, IV hydralazine is really not indicated for anything. And when you look at its basically you give hydralazine to someone and there is no way to predict how much it's going to decrease the blood pressure. It can decrease it by 10 points, it can decrease it by 30 points. There's really no way of telling. And then you also give hydralazine, and the metabolism of the drug is variable. In some people it can disappear within a few hours, or it can last for up to 12 hours. So then there really is no good way to predict how hydralazine is going to fix this high blood pressure, is going to improve it, whether it's going to improve it just enough so that that doesn't cause any complications. And so I think it is a harmful medication in that sense. I think up to 10% of patients who get it do report some kind of bad outcome. Like even if their blood pressure is not low, they still report dizziness and lightheadedness and not feeling well. So yeah, I think since this write-up, I've definitely not used hydralazine.
I think we should move on to our final topic, which I mean, at least for me, this might be the quickest part of this because I know the least about this, the evidence here. And I'll go ahead and read this case. This is a 54-year-old obese male with CKD3, hypertension, HFpEF, and osteoarthritis is admitted for a total knee replacement. His medications include HCTZ, lisinopril, naproxen, and sertraline. You are seeing the patient in clinic for a pre-op evaluation, and he asks if he should hold any of his medications before surgery. So, of course, that medications before surgery is a huge topic, but we're going to be very narrow here. So we're going to talk about the ACE inhibitor. Pascale, should we be concerned if we're going to be using an ACE inhibitor? And I guess we'll include with that angiotensin receptor blockers as well before surgery. Should we be concerned there?
So the short answer is I don't know. So this is, like you guys said, like the topic that I never knew I should be thinking about. So I guess, so Charlie actually came up with this topic. And when I was reading about it, it's really, like there's really not much out there. So I guess you have a patient on an ACE inhibitor or an ARB for very good indications. They need to be on the drug, but they're going for surgery in a few days. Do you want to stop the medication or do you want to continue it? And there's really no good answer there. You can stop it, but then the patient's blood pressure is like 200 over 120 and they're having a hypertensive emergency and the surgery is postponed. Or you can give them the drug and they go into the OR and then they're on pressors in the ICU afterwards. So I guess deciding whether to keep it or not keep it is an area of debate. And I would love to hear from Charlie, since I think the hospitalists are the people who like do the perioperative evaluation the most and get to decide this.
Yeah, this is a really interesting topic and hits sort of close to home. I practice on a co-management service at the VA, and to get to the heart of the matter is our group has sort of sat around on multiple occasions, and we have a perioperative expert at our institution, and we've sort of discussed this idea of the use of perioperative ACE inhibitors and ARBs. And we come to different answers and conclusions like every other month. Like 1 month we're like, hold them. And the next month we're like, no, it's okay. And so I think I've just resulted in like, I hold them on Monday, Wednesdays, Fridays, and then like give them on Tuesdays and Thursdays at this point in time, because, Pascale is right. When you sort of sit down and look at the data, it's all observation. It's all retrospective stuff. So it's really difficult to sort of interpret. If you also look at all the different guidelines, from the AHA guidelines to the Canadian guidelines, they all sort of say mildly disparate things. Some saying go ahead and hold, while others saying it's okay to give in the perioperative period. So, I think as practitioners, as hospitalists, as co-managers, we're really sort of shrugging our shoulders right now. We really don't know what to do. The other interesting thing I find with this is what are the outcomes we're actually looking at? The idea of intraoperative hypotension, like what does that mean in some capacity, and how clinically significant is that? I've seen that as an outcome on several of these studies. And if there are no long-term ramifications of that, is that necessarily a bad thing? And I don't know. And so I think, like the rest of us here, I'm again shrugging my shoulders going, I don't know what to do here. And somebody, please help me.
Well, what I would say is the most concerning is, it's easy to say, it's only retrospective and observational data. But one of those retrospective and observational studies showed a survival signal, right? A 20% increase in mortality in patients that continued on ACE inhibitors for, non-operative, non-cardiothoracic surgery. And that's the kind of thing that gets my attention. Right. And then consistently in these observational trials, and actually there have been a couple of randomized trials, though small, they have shown this consistent intraoperative hypotension, though usually not postoperative. And it makes sense, right? You are essentially eliminating one of the central mechanisms for maintaining blood pressure, for having a counterregulatory response when your blood pressure drops is using the renin-angiotensin-aldosterone system. And so again, I had no idea this was even on the radar, and the more I looked into it, the more concerned I got. And I think, a lot of people, we're adding the ACE inhibitors to get that blood pressure from 140 to 125. In that situation, I think trimming that blood pressure, that ACE inhibitor before the surgery, has very little negative consequences as long as it gets resumed afterwards. But I think what Pascale was saying is the reason we're not coming strong with a recommendation is the right study has not been done. We don't have a large RCT to answer this question.
Mm-hmm.
In your collective experiences, does the acuity of the patient make a difference? Because I would argue, like, the patient who comes in septic and maybe needs an urgent surgery, like an amputation for a neck fascia and osteo, is different than someone coming in for a total knee. And so, is that, all things being equal, and electrolytes say that those parts are okay? Does that matter or seem to make a difference in terms of what's been looked at?
Sorry.
Usually the studies have been limited to patients with planned outpatient studies. Right. That they're excluding emergent surgery so that they can actually randomize, not so much randomize, but give patients an opportunity to stop the drug.
Right.
Well, tying both of these topics together, I have to say that when I venture down to the PACU, or when I look at like what happened in the operating room, and the medications that were given, I am like horrified. Anesthesia is like a different world. I'm like, wait a minute. The patient got 20 of IV hydralazine, their pressure tank. Then they were on phenylephrine.
Right.
And then they got more hydralazine because the blood pressure went up above 220. I'm not kidding. These are real things I've seen.
Never consulting nephrology for ATN 2 days later. Yeah. Yeah. It's I almost try to just ignore the op note unless something goes wrong, and unless something goes wrong and I need to look, I just don't look at it.
I just see Kidney Boy with his head down there.
Ignorance is bliss.
Yeah, we've definitely stepped on a landmine that we have no idea what to do with. This is an issue that I get surprisingly few questions for, and I was surprised to see how robust, though limited, the literature was. There was a lot of people that had looked at this question, though they had not been able to come to conclusive answers.
Yeah, it might be one of those things where it makes sense if you have a patient that you know has just like crazy hypertension that's like really difficult to control, and they're finely controlled, you might want to make as few changes as possible to their regimen perioperatively. But if you have like I saw a cash slack recently, the little old lady with a blood pressure of 120 who's on 20 of lisinopril and she's going into the OR, I am not putting her on lisinopril pre-op. But outside those two extreme examples, all the patients in the middle, I don't know what I'll do.
I'm glad we can provide guidance here.
We'll probably never have an answer for this, to be honest.
Yeah, I generally don't hold it if they can tolerate the pressures, but...
So let's go around, and does anybody... So this episode on PRN hydralazine or PIN anti-hypertensive medications and perioperative ACE inhibitor, Pascale, did you have any take-home points that you wanted to give the audience? Any things that you wanted them specifically to remember about this?
Yeah, I think specifically in the PRN anti-hypertensive management, I think just stopping the use of IV PRN medications is key. Outpatient management of hypertensive urgencies, and really assessing the patient the patient with high blood pressure at the bedside, and kind of looking at what is causing this high blood pressure instead of reacting and just giving IV medicines.
Charlie?
Yeah, I would just echo what Pascale sort of mentioned at that point in time. Whenever I'm seeing an elevated blood pressure, I'm going back to the patient's outpatient medication regimen and seeing what was dropped on admission, what can be added back on. I think there have been some studies in the past that show that those who were given PRN medications for their blood pressure control, about 40% of them had not actually been continued on their home medications. So that's a great place that I'm actually starting at whenever I'm looking into this.
Okay, Chief, we'll end with you. Any final words of wisdom?
Yeah, no, I think Dr. Khairallah absolutely nailed it. She got the three key pieces. One, stop giving IV medications if you don't have, an aneurysm or, crushing substernal chest pain, right? Just stay away from those. 2, when you get called, go see the patient. And 3, when the blood pressure is really high in the clinic, the ER is not your friend. Take care of the patient right in front of you right then, and just get a quick follow-up.
Okay. And everybody, don't forget to fill out your brackets for NephMadness. I think this is coming out before the tournament starts. Or actually, do these have to come out during the tournament, Joel?
Please, these need to come out after the tournament started.
After the tournament starts.
After the tournament started. We're not, after March 15th.
Okay. But they can they still fill out brackets at that point? That's what I'm saying.
You can fill out brackets between March 15th and March 31st. The first round results will be announced on April 1st. So we'll reveal the brackets on March 15th. This podcast will come out sometime after that. Fill out your brackets, and then hold on to your butts on April 1st, because we're going to be every other day. Every other day we're going to be having we'll have a different round being announced, and I think April 8th is I believe that's the champion will be crowned.
And what's the? Do you have prizes yet? I think last time we spoke to you,
we've got prizes. I don't remember what, but they're great. I think we have the towels. I think that's what we're doing. I've
seen shirts.
There's shirts. Yeah. I know if the team who has the best bracket, or the person who gets the best bracket, I think they get a textbook. The primer, the National Kidney Foundation primer on renal disease is actually a really good book.
Okay.
It's like it's one of those books that's like meant to be read rather than displayed.
So, so what I'm hearing, and what I'm hearing here is bragging rights are one of the key things that you're going for in this.
There's a new category. There's a new category to win this year. It's Best NephMadness Themed Party. VCU last year went bananas and had an outstanding party, and really have set the bar quite high. So if you can organize a great NephMadness party and document it on social media, there's a special award just waiting for you.
And that was not a potassium pun, I hope, because I will throw myself right out the window.
Yeah, tell us about the pun contest. What's that all about?
Well, so our esteemed team at the Curbsiders, we want some NephMadness themed puns. Give me a second to pull this up because this is Hannah's brainstorm here. So I don't know that I even fully understand what is going on. Joel, I've lost control of the team at the Curbsiders. Which I think is a good sign that things are going well, that things are being created without my knowledge. And
I think it's cute that you think you ever had control of the team.
I have to say, I tendered my resignation in this thread and then immediately got some panicked emails from some of my colleagues, so I had to take that joke down almost immediately.
Hey, can we go around the horn and have everybody pick LR versus saline, and then perioperative ACE inhibitors versus PRN hydralazine?
Yeah, that's a good idea. Okay,
Dr. Khairallah, you want to start off?
Yes, I go with LR and PRN hydralazine.
And then between those two, who wins?
The PRN hydralazine.
PRN hydralazine emerging from the hospitalist nephrology. Paul, you want to venture?
Yeah, I'll do LR and PRN hydralazine as well.
And then emerging from that battle?
And then emerging, I think LR. I think I'm going to go with LR.
Okay, Stuart?
I'm going to go LR and PRN hydralazine as well. And in this case, LR.
Okay. Charlie?
I'll do LR and the PR hydralazine, and I'm going to go hydralazine.
Yay.
Matt?
Before I answer, how does the blue ribbon panel judge based on evidence or just based on like what is the more fun or the more like sort of engaging topic?
Don't ask that question, just answer.
It is so confusing and confounding what the blue ribbon panel does. You
created this. You're just like me. You don't know what's going on in your own organization.
That's the thing. I feel much more strongly about PRN hydralazine, but I feel like the evidence is now more compelling for the LR versus the normal saline.
Yeah.
So if we're going evidence, LR. If we're going something I could scream about all day long, then PRN hydralazine forever and ever.
Go with screaming.
I am duplicating Paul's bracket. Control C, Control V, Paul's bracket. That's that's what I'm going with.
So all the Curbsiders agree.
I'm going to go with LR followed by PRN hydralazine and then PRN hydralazine winning the hospitalist bracket. I think
Yeah.
So all of our guests have the same bracket and all the Curbsiders had the same bracket. Who'd have thunk it?
Bodes not well.
Right, I'm sure it's going to be normal saline and ACE inhibitors with ACE inhibitors. Like, what are we doing?
Okay. Well, this was really fun. Joel, I think this worked well. Justin, great job putting this together, this script.
Yeah.
Thank you, guys.
Wait, what was Justin's pick? He's got to be the tiebreaker. Justin, come on.
Guys, I thought this out a lot, and I think Lactated Rangers, it's an overrated favorite. They had a big year, but Normal Saline has strong fundamentals. They've had good performance in the past. I think the Blue Ribbon panel is going to reward their consistency, and Normal Saline all the way.
Normal Saline's like the Patriots of this.
If Normal Saline wins NephMadness, that is one of the biggest upsets of all time.
You heard it here first.
It'll be just like the past Super Bowl.
Yeah.
You know what?
Just as boring.
I'm sure he's got it nailed it.
Right, exactly.
That's what I'm thinking about. I'm like, you know what? That's going to be it.
That was well said. Well said.
Here we honor tradition. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
Thank you. We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review. Please review the show on iTunes or contact us at thecurbsiders@gmail.com. A special thanks to our producer for this episode, Justin Berk, and as always, to our social media team, Hannah R. Abrams on Twitter, Beth Garbatelli on Instagram, and Chris the Chew Man Chew on Facebook. Until next time, I'm Dr. Stuart Kent Brigham.
I often wonder what it's like to be in your head, Stuart. It's always
horrible.
Interesting. To watch from the outside is interesting. I've been Dr. Matthew Frank Watto.
Behind the curtain, he's recording in total darkness now, for reasons completely unclear to the rest of us. I remain Dr. Paul Nelson Williams. Thank you, and good night.
Good night. You can see my eyes.
I know, but it's just like you go to your you like turn the camera off for a while, and then you come back and it's like complete darkness, and like once in a while it's like Sin City, like we just see your glasses glaring, like what's his name from Sin City? I can't.
It's a Frank Miller comic. Yeah, that's perfect.
What's his name again? I forgot.
It's like the album cover of Bohemian Rhapsody before people on Queen.